Good evening. My name is Roxanne from RBC Consultants. Welcome to another International Dermatology Education Foundation Educational Series Webinar. This evening, we are going to be talking about modulating the androgen-sebum pathway with an androgen receptor inhibitor. Our moderator this evening is Dr. Leon Kircik, who is the president of the International Dermatology Education Foundation, as well as clinical professor of dermatology at the Icahn School of Medicine at Mount Sinai in New York, Indiana University Medical Center in Indianapolis, and medical director of physician skincare, DermResearch, and skin sciences in Louisville, Kentucky. Our speaker this evening is Dr. James Q. Del Rosso, who is adjunct clinical professor in dermatology at the Touro University, Nevada, and Henderson, Nevada, research director, principal investigator at JDR Dermatology Research in Las Vegas, Nevada, senior vice president of clinical research and strategic development, advanced dermatology and cosmetic surgery in Maitland, Florida, and president-elect of the American Acne and Rosacea Society. We'd like to thank our supporter, Sun Pharma, for making this educational event possible. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues, please submit your questions in the question chat pane on the right-hand side of your screen. At the end of the webinar, a survey will pop up in your browser and will be emailed to you 1 to 2 days later. We'd greatly appreciate it if you could fill it in and send it back to us. Finally, within 1 to 2 days of the webinar, a certificate of attendance will be sent to you. If you want to submit questions to our faculty, please use the question chat pane on the right-hand side of your screen. And I wrote a little note there so you can see exactly where you need to type in your question. So without further ado, I will pass the floor virtually to Dr. Leon Kircik.
Good evening, everyone, and thank you for joining us tonight for another educational series from International Dermatology Education Foundation. Tonight, we are very lucky to have Dr. James Del Rosso, who's going to speak to us on acne vulgaris. However, before we do that, I'd like to tell you a little bit about my foundation, International Dermatology Education Foundation. And we are a nonprofit organization whose principal mission is to raise awareness and improve dermatology care all over the world through education, especially in underserved areas. And if you can take a look at the next slide, where we have several of our programs, we have served our audiences all the way from North America to South America, globally across the globe in Europe, Southeast Asia, and even in China. So I'd like to thank you for joining us tonight. And without any further ado, I'd like to introduce you to Dr. Del Rosso, where he's going to talk to us about clascoterone cream and modulating the androgen-sebum pathway with an androgen receptor inhibitor. Welcome, Jim. Thank you so much for doing this to us. Thanks
a lot. Thanks a lot, Leon. I certainly appreciate the opportunity. You know, we've worked on this area for quite a while. A lot of the background information, and certainly know about clascoterone Winlevi cream. So I appreciate the opportunity. And periodically, Leon, I am going to tap into your brain because I know you know a lot of this area. So we will get a little bit of dialogue and not just my talking head, which I'm already tired of hearing myself. I'm already tired of hearing myself. So
well,
so anyway,
the rest of us aren't. So don't worry.
All right, I'll keep going then. Thank you. So we're going to be talking about modulating the androgen-sebum pathway with an androgen receptor inhibitor. And I think it's really important because when we talk about acne, and certainly androgens have a lot of other functions in humans, but when we talk about acne specifically, if there are no androgens, there's no sebum. And if there's no sebum, there's no acne. And that's something that I heard Hillary Baldwin say one time, and it's a beautiful synopsis of what we're going to be talking about. Right? So we'll move on here. All right. So this is let's go back here. Right. So this is not a CME program. So it's developed on behalf of Sun Pharma. So we are required to stay within the FDA approved labeling, and we certainly will do that. I've received compensation from Sun Pharma with regard to this presentation based on fair market value, and all of that is pursuant to open payment. You know, anybody can look at whatever it is I'm getting paid because it's an honest day's pay for an honest day's work, and the prescribing information is there for you. So we're going to be talking about a few different areas, and the first one is extremely important, and it's something that we haven't really talked about a lot in dermatology and haven't really recognized. We understand that the skin is affected by a lot of different circulating mediators, and certainly androgens and hormones are a significant factor, but we haven't recognized that the skin in and of itself is an androgen organ. It can produce androgens on its own. It could produce dihydrotestosterone. So there may be no influence from what's in the systemic circulation. And that's extremely important. That has everything to do with acne, both in terms of the pathophysiology of acne and how we target acne in terms of treatment, making sense to have topical therapies that get to the target organ and try to spare systemic exposure if we're not looking for a systemic effect that can lead to adverse effects, but not necessarily therapeutic effects. Also, we're going to be talking about the 4 classical pillars of acne pathogenesis. Then we'll talk about clascoterone, which is available topically as a 1% cream under the brand name of Winlevi. It's the first agent that is available that's FDA approved, that's a topical androgen receptor inhibitor, and it's the only one that's approved that can be used in males as well as females, because the hormonal aspects of acne are true in both genders, both males and females. We've concentrated on the females primarily because we've only had oral contraceptives and spironolactone off label, and those can only be used in females and women or girls. However, the process of what's going on pathophysiologically is not gender specific. It's males and females. Then we'll be going over efficacy and safety data. So when we look at the skin as an endocrine organ, this is a very important slide. And what it's trying to show you is that you certainly have androgen producing organs like the adrenal glands and gonadal tissue, and there's contributions are different depending on whether it's a male or female, and how androgens and estrogens are produced certainly differ between males and females, but they're synthesized in both. And we've always talked about the effect of androgens. We focused on the adult female with acne and whether or not we thought she had polycystic ovary syndrome, a polycystic ovarian disease, as a source of androgens. There can certainly be other androgen excess syndrome. And we thought about that because if these circulating androgens are increased, they're obviously getting into the skin and they're associated with acne, you know, with abnormal menses, with abnormal hair growth, right, in areas where you don't want to have the hair, but loss of hair on the scalp, and other problems that can occur when you have systemic androgen excess. But the fact of the matter is the skin in and of itself is capable of producing androgens, and you have circulating precursors like cholesterols and other agents that get into the skin, and there are converting enzymes that within the skin make androgens like dihydrotestosterone. So that's extremely important to recognize, because much of the acne we see where there's no androgen excess in the females or the males, the skin, the production of androgens within the skin are very important. And that can happen to different degrees in different individuals, depending on what's happening with those converting enzyme systems within the skin. So it's very important to recognize that the skin is really the primary target. Unless we have an androgen excess syndrome systemically, the skin is the primary target of what we're trying to treat. And we haven't recognized that to date. And the picture will show you here, it doesn't matter what color their skin is. It's an equal opportunity disease. It's an equal opportunity situation in both males and females and any race, color, or creed. But this is a really important point that we've not spent enough time talking about in dermatology. And there's a lot of data to support it. Now, what happens is when androgens, especially dihydrotestosterone, that's the major one, it's not the only one. But when we have that within the skin, and that can certainly be contributed from systemic circulation, but it's really independent of that. If you don't have an androgen excess, you can have the androgens produced in the skin that can lead to acne. And it certainly does that in millions of people, right? In pre-adolescents, in adolescents, teenagers, and even well into the 20s, 30s, and 40s, we see people that have acne. And what those androgens do, right? You have dihydrotestosterone binding to the androgen receptors, and those androgens stimulate sebocytes, so you see an actual increase in the size of the sebaceous glands and to some extent the number. And then you have sebaceous lipids that are produced that create sebum, but there's also another component. There are inflammatory cytokines that are produced by the sebocytes. So it's not only the presence of sebum, which then allows C. acnes, Acutibacterium acnes, which was previously called Propionibacterium acnes, same organism that was renamed, that will then proliferate. And if there's pro-inflammatory strains of that organism, you can see inflammation, but you can see also contribution to comedones, what we call non-inflammatory lesions when they're visible, but there's inflammation going on with all of these lesions. So patients with acne vulgaris, they're having this production of dihydrotestosterone and testosterone within the skin, and the skin itself is producing much of that androgen. So that's extremely important. Now, this is an important slide to walk through. So this is happening in the very beginning when you have adrenarche and now you have androgens being produced in young boys or young girls, and then you have puberty, and you have certainly androgens being produced. That's when we typically start seeing acne in the vast majority of people. And before that, there was little to no sebum. That's why we weren't seeing acne. So this is really the first step. And even later on, as time goes on, because these receptors are constantly being turned over and there's new receptors and there's new cells, this process is continuing not only at puberty, but throughout life with the potential of acne lesions being formed. But the androgen involvement is the first step. Now, we haven't talked about that a lot when we've talked about acne because we've had therapies that targeted, for example, Propionibacterium acnes. So we focused on that and everything that led to. We focused on reducing follicular hyperkeratinization, occlusion with topical retinoids, oral antibiotics, some of the anti-inflammatory effects, and some of the effects on reducing the organisms. And then isotretinoin really on every level. That's a different situation, but it's not a direct androgen inhibitor. It just basically, gets rid of sebaceous glands, but it's reducing the sebum in that way. But when we look at what's actually happening here, and we have these androgen receptors that are now being stimulated by the androgens, you see here on the bottom, you see the increased production of sebaceous lipids and the increase in the size of the sebaceous glands and even the number, but primarily the size of sebaceous glands with far more sebum produced. That leads to that C. acnes proliferation. Right? C. acnes needs that sebum for its nourishment. And then that C. acnes can increase inflammation by a variety of different mechanisms. And Dr. Kircik and I published a supplement some years back that goes through a lot of this in more detail in Journal of Drugs and Dermatology that you can certainly reference. But then you also have that increased cytokine, inflammatory cytokine production that happens as a result of this. Then around the same time, right, the sequence is not exactly simultaneous, but it's all happening as acne lesions are forming in a given follicle. This is happening independently in different follicles at different points in time. You have the follicular hyperkeratinization, which is what forms the microcomedone, then the comedonal lesion, right, which is when we see it visibly in open or closed comedone. And the combination of that inflammation and that hyperkeratinization with the follicular occlusion leads to the formation of acne lesions. Comedones, open and closed, papules, pustules, nodules can form, and then subsequently that follicle will go through its life cycle and either leave dyschromia, hyperpigmentation in darker skin, erythema in lighter skin, persistent erythema in lighter skin, normal skin, hopefully. I was fortunate to have that. You didn't have much acne scarring. That's likely on a genetic basis, right? Or acne scarring in some individuals within individual follicles. So this is what we've had, but our therapies have focused on what? They focused on reducing the C. acnes and reducing the hyperkeratinization primarily, and some of the inflammation that happens subsequently. And then if you utilize spironolactone and oral contraceptives in women, you can have some effect on reducing the androgen effect and reducing the sebum effect to some degree, right? So that was really all we had, but we didn't have anything that truly inhibited androgen receptors and the androgen effect. That's why we didn't talk about it. But it's on the beginning, it's on the left-hand side. So all these years, we've had that left open in the majority of the patients because we didn't have any therapies to address it. And then certainly only some people would be on isotretinoin to address all of these pathways. So now topically addressing all four pillars of the pathogenesis. If we want to target acne, we typically use combinations of different agents. We might use benzoyl peroxide with a topical antibiotic. Nowadays, we're typically using clindamycin. We might utilize a topical retinoid with that. There are other agents you could use like azelaic acid or dapsone, topical dapsone, maybe oral antibiotics in some cases in combination with some of those other therapies. But each of those is affecting portions of those pillars, but none of them are addressing the androgen situation, the androgens in the sebum. So we at most have 3 pillars covered, but we don't have the 4th pillar covered, okay? So that's where we've really had a problem with addressing with topical therapy, is that 4th pillar is left uncovered. So in 2016, we had the American Academy of Dermatology acne guidelines. Topical therapy is certainly foundational. You can add on oral therapy, typically an oral antibiotic, maybe one of those other agents in female patients that we talked about, some of the oral therapies. But we now have an updated acne guidelines from the AAD. Significant advances have come along. For example, topical clascoterone wasn't around for the 2016 guidelines. It is covered in the recent guidelines that were just published from the American Academy of Dermatology. These are not laws, they are not mandates, they are guidelines, and they give you suggestions where they're looking at it from a very academic levels of evidence to support research and some practical guidelines. But ultimately, you're the clinician, you're the one that really needs to put it all together and figure out what's best in your patient. Prior to the approval of clascoterone, topical clascoterone, the Winleve 1% cream, we haven't had topical therapy that addresses androgen excess or sebum production. You could give a patient certain therapies, like a topical retinoids, for example, or some vehicles that have a drying effect on the skin, and you may get the sense that there's decreased sebum, but they're not actually affecting sebaceous lipid production. The only agent that we really have that does that systemically is isotretinoin. So now moving forward, you see across the top, you have clascoterone, antibiotics, retinoids, benzoyl peroxide, azelaic acid, and dapsone. The antibiotics are available topically and orally. Dapsone's available systemically, but here we're talking about topical dapsone, and we're talking here about, pretty much topical retinoids. This is really addressing topical therapy. When you look at what is being addressed by these different agents, hyperkeratinization is primarily retinoids, some from benzoyl peroxide, azelaic acid, weak with the antibiotics, and actually clascoterone and dapsone both inhibit comedonal lesions, which means they're going to have an effect on that particular system. We just don't have as much of the basic science evidence with the clascoterone and the dapsone, but by their mechanisms, they reduce comedonal lesions. So they're not only for inflammatory acne lesions, and their pivotal trials and subsequent trials support that. Inflammatory pathways, all of them. So clascoterone gets a check mark there. C. acnes proliferation, okay, gets a check mark there. And androgen-induced sebum production by inhibiting sebaceous lipids. Clascoterone is the only one that checks off that box. So of the topical agents, it's the only one that affects that androgen sebum pathway of everything else we have there. So if you're looking at, in real world, the way we combine different topical therapies, in order to topically address the androgen sebum pathway, topical clascoterone would need to be used in that patient. All the other therapies would be addressing all the other pillars, the other three pillars, right? But not necessarily the androgens. So that's an important point to recognize. So now the oral therapies, you see here, you have the combination oral contraceptives. There are a few that have been FDA approved. The data supports that any of them can be effective, but they don't all have FDA approval. And then there's the aldosterone antagonist, spironolactone, which is an off-label therapy, developed initially as a potassium-sparing diuretic, approved for hypertension and for other disease states, the patients that have cardiac disease, where you're trying to reduce edema and be cautious about potassium loss, right? Like other diuretics can do. And then later on, it was recognized that they inhibit androgens, right? And that's how they started being used off-label in conditions like acne. If we look to the right, hormonal therapies are not recommended for, and what actually all acne is hormonal. Hormonal is involved with all cases of acne vulgaris, the common form of acne, which we're talking about. But when we're looking here with the agents that are listed on this slide, they're all addressed toward women. And so they're not recommended in men. You don't give men oral contraceptives or spironolactone for acne, right? In pregnant or lactating women, or in those receiving testosterone, you have to be very, very careful depending on what they're utilizing the testosterone for. In women with oral contraceptives, you have to be cautious if it states over the age of 85, over the age of 35, sorry about that, over the age of 35 or older actually, and heavy smokers, because that increases the risk of venous thromboembolism over and above the oral contraceptives alone. So that's something that's always in the back of your mind. So when you're utilizing these oral therapies, there are some systemic implications you need to think about that are not concerns with oral clascoterone as an androgen receptor inhibitor. So this is a video we'd like you to listen to.
A chronic inflammatory skin condition presenting as papules and pustules on the skin is caused by the blockage and inflammation of pilosebaceous units, primarily on the face and upper trunk. Acne is triggered by an increase in androgens, whether due to circulating androgens or those synthesized within the skin. These androgens stimulate the sebaceous gland, beginning at puberty in both females and males. Androgens such as dihydrotestosterone or DHT bind to androgen receptors in sebocytes. The receptor then
Know what happened with it? I think it punked out on us.
I think we just the volume. Yep. I think you're right, Dr. Del Rosso.
Yeah, I'm going to move on. I don't want to, in the interest of time. It's basically a summary of what we already said.
condition presenting as
So let's move, see if we can move. There we go. So let's go to understanding clascoterone. One back. Okay. It's a little, okay. So there are in vitro studies supporting the activity that we talked about. It's not just theoretical based on knowing about the androgen receptor inhibition. Clascoterone, what does it actually bring to the table? So if you look at these three compounds on the right, they all have a 4-ring backbone, which is called a steroidal backbone, okay? Because many steroidal compounds use a 4-ring backbone. That doesn't mean glucocorticoid, that doesn't mean corticosteroid. It really depends on the compound. So clascoterone is an androgen receptor inhibitor. Dihydrotestosterone is an androgen. Spironolactone is an aldosterone antagonist, which actually has some androgen inhibition activity. So those are three different compounds. The difference is based on their side chains that creates differences in the functions of these different agents that have a backbone. And we certainly know that from many other drugs and compounds and chemicals that we have. So clascoterone competitively binds to androgen receptors and blocks DHT, whether it came from the systemic circulation or whether it was synthesized within the skin. Okay. So now we're looking at an example here. On the left, you see here clascoterone with the, that's what's with the blue triangle. You see dichlorophenyl dichloroethylene, which is a low affinity binder to androgen receptor. Dihydrotestosterone's a high affinity binder, right? And then where does clascoterone fit in binding to the androgen receptor? Well, it's not the high affinity of dihydrotestosterone. And so it's not blocking all the activity of dihydrotestosterone. And so we're not shutting it down like a light switch. And actually, that's somewhat important because you do want to have some of the physiologic activity of hormones that you're directing your therapy against. You just want to turn down the volume knob of the activity. So the clascoterone actually has more activity than that dichlorophenyl chloroethylene, right? Dichloroethylene. It has more, but doesn't bind as avidly as dihydrotestosterone, which is okay, you know. And now you're looking at inhibition of androgen receptors. So by doing that, you would block the transcription that happens. That's the downstream effect of binding to the androgen receptor. And here you're comparing clascoterone with enzalutamide. Enzalutamide is available as a treatment for advanced prostate cancer because you want to inhibit the androgen activity in that particular disease state. So it's separately, it's a systemic agent, it's available on the market. Clascoterone is a topical agent being used to inhibit androgen receptors for acne. And you can see here, the results are fairly close, right? In terms of the relative antagonist activity by blocking the androgen receptors and their downstream effect. So we can see here that clascoterone does have the binding to the androgen receptors, and it can inhibit the downstream effect of that binding. Now we're moving on to the other effects that we talked about. Can clascoterone inhibit lipid synthesis? And here we're looking at an assay. On the left, you see the relative lipid level is what we're seeing from bottom to top, and all the way across on the bottom axis is DHT concentration. And so we're comparing clascoterone, spironolactone, and vehicle in an in vitro assay to look at what's the effect on lipid production, lipid synthesis. This is in vitro, trying to stimulate the DHT stimulated sebocytes. And clascoterone at 7 days reached about 50% reduction. And it actually did better in many of the controls that were looked at than spironolactone and any of the assays, I'd say individual assays, right? You see the vehicle control obviously had less effect. Then if you go to the right, you'll see clascoterone and spironolactone both, their ability to inhibit cytokine secretion. You can see here, both the clascoterone and the spironolactone were effective in doing that, but the clascoterone actually did better in most of the donors than the spironolactone based on an in vitro assay. We cannot make a claim that it means it's more effective therapeutically in patients. This is just showing activity in a in vitro assay, but it's making the point that clascoterone inhibits the lipid synthesis by sebocytes and reduces the inflammatory cytokine secretion by those sebocytes. Right? So now we're looking at what happens to clascoterone. It's metabolized, okay? It's esterified first to cortexolone 21-propionate. That happens as an intermediary step, and then it's hydrolyzed to cortexolone, which doesn't have any topical and systemic anti-androgen activity, but the cortexolone 21-propionate has modest glucocorticoid activity for a relatively short period of time. You're seeing here that essentially what's happening here is the majority of that is gone within 6 hours, right? So you have very little of that, but it's there. So that's why you're going to see why HPA axis suppression was evaluated. And fortunately, as it turned out, it didn't show that it was of significance enough that you need to monitor any kind of laboratory tests when you're utilizing clascoterone for acne. And there was no further request by the FDA after phase 2 to look at HPA axis suppression. The few modest cases that happened were minimal in effect, and they were reversible. So HPA axis suppression, and I'll show you that shortly, turned out not to be clinically relevant moving forward. And if you utilize topical clascoterone as recommended, it's not felt to be a clinical concern. But that's why it was tested. Okay. So in summary, clascoterone binds to androgen receptors, inhibits androgen receptor activity, inhibits the lipid synthesis induced by dihydrotestosterone, a marker for sebum production, inhibits the cytokine secretion induced by the androgens dihydrotestosterone, and it's rapidly metabolized to cortexolone, which doesn't have the anti-androgen activity and is not a glucocorticoid. Right? So now let's move on to safety evaluations through the clinical trial development. So clascoterone versus glucocorticoids like hydrocortisone, where this is typically where we see HPA axis suppression evaluated, but I explained to you why it was evaluated here. And essentially what they did, okay, is there were 22 adolescents and 20 adults. You can see the age breakdown, the numbers of patients, and the body surface areas, a maximum use study. So a prescription for Winlevi, okay, the Winlevi package insert recommends approximately 1 gram twice a day, 1 gram per application. Remember, a fingertip unit, it's about 0.5 gram. So putting up to 1 gram on the face and any other affected areas that they might have, it can be applied anywhere the individual has any severity of acne. You apply it to the skin, not dotted on, but apply it diffusely to that area. That's 2 grams a day. In this study, they were applying 4 to 6 times the recommended dose when they evaluated the plasma concentrations and the HPA axis. So it was far more than what you typically be using in clinical practice. And these were patients that actually had moderate to severe acne on the face, chest, and back. Right? And so let's see here. So here you're seeing that there were 3 patients that had modest temporary HPA axis suppression. Was applied the treatment over 14 days, okay? And then 2 weeks after that, after it was stopped, they evaluated. Those effects are reversible. Evaluation of looking at serum concentrations, there was no relationship that was observed. There was no clear relationship between HPA axis suppression and systemic exposure to clascoterone. So there was no requirement that you need to do laboratory monitoring like electrolytes, et cetera, or to even evaluate for HPA axis suppression when you're utilizing topical clascoterone as recommended. And this was in excess of what is recommended in the package insert. So they weren't required to look at it after phase 2, which was good news. So that put that to rest. Now looking at the phase 3 pivotal trials, and Leon, I'm going to call on you on a few areas where I know you have some insights, but this is the important safety information. There's no contraindications. What does that mean? That means that there's no place where somebody could say you should not have used this drug if they were 12 years of age and older and they had acne vulgaris, and that's what you were treating. That's the approved indication. Contraindications means you should not have done it. And nobody can point the finger at you with that based on at least the labeling. The FDA did not see any contraindications to say, Dr. Del Rosso, you shouldn't have used it there. They were 12 years of age and older. They had acne. I was treating the acne with it. I'm on label. Now, the other
Jim,
things.
I don't want to stop you, but I just want to chime in here that how many times do we see such a clean package insert with contraindications? None. I think that's
rare.
really, yeah. I just wanted to chime in because, you know, we don't see it that often.
We don't. It's very uncommon. And the importance of that is to realize that statement is you should absolutely not have done it, right? That's different than a warning or a precaution where you might have had to look out for certain things. But this is saying you shouldn't have done it, Dr. Kircik. Why did you do it? It says it right in the label. So that's an important thing to point out. So you're right. You rarely see that, even with topical drugs. So we're going to go over the local tolerability reactions. Hyperkalemia we will get to in a moment. HPA axis suppression I just addressed, right? And then the other adverse reactions we're going to be talking about that are in the important safety information. So we'll be getting to those. I'm not skirting over them. Okay. So here we're looking at the study design. So it's the typical multi-center randomized double-blind vehicle-controlled studies. So nobody knows at this point, the first 12 weeks, who is getting the active drug, who is getting the vehicle cream. The vehicle cream is the same vehicle without the active drug. And they could be males and females. They were at least 9 years of age, but I'll just give you the punchline right now. The drug got approved 12 years of age and older. They didn't have a large enough population below the age of 12. So they didn't get approval down to 9 years of age, just so you recognize that. They included moderate to severe, IGA of Investigator Global Assessment of 3 or 4, but the approval, the indication, includes mild. So there's no limitation on severity, no limitation on body location, and no limitation on duration of use. So the indication, anywhere they have acne of any severity, for as long as you need to, as long as the acne is there and they're 12 years of age. You have a threshold of comedonal lesions and inflammatory lesions they have to meet. Typically, these people are going to be at about 70, 80, 90 total lesions. It's typically what you're going to see, and up to 2 facial nodules. So these were not nodular acne where you'd be looking at a patient that would be in a isotretinoin study. These are the same type of criteria that are with the approval of all the topicals that we have. All the things we've had over the years, they limit the facial nodules. So this is no different. So you had a little over 700 patients in both groups, in trial 1 and trial 2, approximately 1 gram to the entire facial area. They could use it on the trunk, but the face was only evaluated for efficacy in these first 12 weeks by global assessment and by lesion counts. Right? And so that's twice a day. You don't have to measure it out a gram. It's an approximation, right? And here you're looking at the endpoints were the number of patients that went to clear or almost clear. Most of them were moderate to severe. There were some mild. If they started as mild, they would have to get to completely clear to get a 2-grade improvement. Then the non-inflammatory lesion count and an inflammatory lesion count had to have a numeric and a statistically significant difference between the active and the vehicle. All of those were the co-primary endpoints. So now you're looking at about 60% were female. Okay, the average age here was about 18. So you're going to have some in the 20s and you're going to have some younger. There were very few below the age of 9, as you can see here. Only 13 actively treated, right? And then the majority of them were Fitzpatrick 2 through 4, right? In that range, and about 8 out of 10. A little bit more than that were moderate, the rest was severe. And look at the total lesion counts. It was higher than I even told you, right? It was a little bit over 100 of them, about 60 comedones, and about 40 in that range, papules and pustules, no more than 2 nodules. So these patients had pretty appreciable acne. Remember, they're only getting the clascoterone. They're not being treated with anything else. No cleansers with anything therapeutic, no other topical agents, no oral agents. This is just topical clascoterone, 1% cream twice a day versus its vehicle. So in both of the studies, the blue, significantly superior to the vehicle in both the studies, and very similar results. So they mirrored in both the studies. And if you pull those results on the right, you can see it's about 20% on the Winlevi treated side twice a day and just shy of 8% with the vehicle. So no problem getting approval. The FDA looks for statistical difference, and it was certainly significant here and numerically different, okay? Now moving on to the lesion count changes in both of the studies, the p-values were reached, statistically significant in both, and you can see the pooled results on the bottom. Right? So, and now we're looking at the mean % change in lesions over time. This is important because what you're going to see is this drug really kicks in separating from the vehicle after about week 4. And if you look at data a variety of different ways, this is not a drug you have the patient use in and of itself. Remember, this is monotherapy studies, that you're going to see a big change within the first 3-4 weeks. It's typically going to kick in a little bit longer, So you should expect that depending on how you're utilizing it in the real world practice. The studies were done with monotherapy. Keep that in mind. Think of the mechanism of the drug. It's not quickly, getting a follicle to unplug. It's not quickly blocking an inflammatory mediator. It's going to the source and blocking that progression that happens within acne lesions. So it takes a little longer. That's okay, right? As long as you understand what that drug is doing. And it's the only one that can reach that part of the pathophysiology, topically or in males, right? In male patients that we have. Moving on to the next slide. So here's a couple of examples we see on the left. A female patient in the study at baseline to week 12. And then on the right, we see a male baseline to week 12, right, in the study. And if you were looking at this patient, think about how you might grade that patient. That patient on the left could have been rated moderate or severe. On the right, they wouldn't have been graded clear. They might have been graded mild. Some may have graded them almost clear based on, what they factor in off of the protocol. But if they went from severe or moderate to mild, they would not have been a success in the study because they didn't get to clear or almost clear. But you can see here a substantial difference. And as a corollary to that, you do see some decrease in hyperpigmentation in this particular patient, which is a nice secondary finding. And then you look on the right, you see this patient started likely as a moderate in the study. We don't have those designations, but think about it for yourself if you were the investigator. And then getting to likely almost clear, because some of those areas of dyspigmentation are not palpable. They're not inflamed or raised, or comedones that are raised. So this just gives you an idea as a monotherapy, okay? In a patient that is not a teenager, the patient on the right is a teenager, on the left is not, is past the teenage years. Males, females, doesn't matter. Skin color, doesn't matter. There's no limitations. So now we're looking at the safety profile. And when you look at the end of the 12 weeks, the majority of the treatment emergent adverse events, which is anything that happened during the study, may or may not be specifically related to the drug, right? But it happened while the patient was on either the Winlevi or the vehicle, nobody knowing which one they were getting until after and the codes were broken. And you can see here, there were no severe treatment emergent adverse events. There were no systemic safety signals where something stood out as an anti-androgen effect. We already talked about HPA axis suppression not being an issue in phase 2, no signs of it as a secondary effect in phase 3, and nothing that showed up systemically that was definitely a difference that you could see where, hey, this is happening only with the Winlevi and not the vehicle, because we are going to see nasopharyngitis and some of these other things in any of the groups, especially when you're going through the winter months. It was nice to see that it was actually higher in the vehicle than in the active, right? The vehicle was relatively low, but they were about the same. So the clascoterone itself doesn't seem to contribute any particular problem. Twice a day is what's recommended. That's what was shown in the pivotal trials. There were dose finding studies earlier. Once a day did work, but not as well as twice a day. So the label does recommend twice a day. And part of that is these receptors turn over, and you want to make sure you're maintaining that binding to the receptor. If you have absence of the clascoterone, you're going to open up some of those receptors to being stimulated by the androgens. Okay. So now we go to the long-term extension study. We're getting to the final end. And what we're seeing here is patients completed, right? There was about, a little bit over 1,400 patients in the up to the phase 3. Now you're going into the extension, right? The pivotal trials where it's not blinded. Everybody's getting Winlevi cream. They can apply it to the face, the trunk, if they have it on the trunk. They all had it on the face. Some of them had it on the trunk, and they could apply it to anywhere they had it. And they previously completed the first part of the trial. Some of them could have been in the vehicle. You see 289 of them over the first 12 weeks had gotten the vehicle. 311 had gotten the Winleve twice a day, and they had to be enrolled within 3 days of the prior trial. So they immediately went into this long-term extension. But at that point, they all got the Winleve cream twice a day, including those vehicle patients. Now, throughout this study, they're being seen at 1 month, 3 months, 6 months, and 9 months. So the people that were in the first 3 months that got Winleve are getting it for a total of up to 12 months. The people that are on the vehicle the first 3 months are then being switched to Winleve, so they're getting it to up to 9 months. So there's a little bit difference in the groups, and they could also start and stop. If they got to clear or almost clear, they could stop the Winleve and then restart it if they got to mild or worse. So they weren't all necessarily getting the drug every day throughout the study. They were assessed for safety, as you always would, local skin reactions, systemic reactions, but you're looking here at the patients getting to clear or almost clear on both the face and the trunk. So the overall population in terms of the treatment emergent adverse events were no different, and the types of reactions that were seen and their magnitude was no different than in the first 3 months. So nothing popped up as being new. Oh, this happened suddenly at month 6 or month 8 with the Winleve, and we never saw it before. So it was consistent in that regard. So that was good news. But now we're looking at adverse effects, scaling, dryness, erythema, redness, itching. What you will see, you're seeing on the left, the patients that had gotten the Winleve for up to 12 months, because they used it during the first 3 months, 311 of them. And on the right, the patients that switched from the vehicle to the next 9 months on and off with the Winleve cream. And you see here that, you know, up to 1 out of 10, typically less, might have some of these effects. And the vehicle is believed to be a part of that in some of the patients. Fortunately, it's relatively mild, and it typically did not lead to the patients needing to stop. And you utilize basic general measures to deal with that. Maybe discontinue for a couple of days or go to every other day and bring it back. Utilize a moisturizer, a gentle cleanser. That's how this is typically handled in the real world and could have been in the study, depending on the investigator. But you couldn't treat them with something therapeutically, or they'd have to be dropped out of the study. Now, this is an important slide, and I'm going to ask Leon to comment on this, but just what you're seeing, the green, the lime green, are the patients that were on clascoterone and stayed on clascoterone through the entire time. Patients that were on vehicle and switched to clascoterone, and then the total number. And you're seeing what happened, how the numbers climb up. The longer you use it, whether it doesn't matter if it's the face or the trunk, right? This is showing facial, but I can tell you the trunk also improved over time. You're seeing more and more people as they keep using it, getting to clear or almost clear. Remember, they didn't use any other therapy. But Leon, I know you have a couple of observations here on this part of the study.
So thanks for including me. Actually, you know, when I saw this slide first, when I look at the total numbers at baseline, it's the IGA improvement is 13%. However, I remember originally when you showed the end of the phase 3 trial at the end of 12 weeks, that number was about 18-19%. So what happened here? I guess what happened here was all comers were included in this study, open label, so that included the vehicle people, which diluted the numbers down to 13.5% from 18 to 19%. Right. That was my first observation. Then the other thing is the vehicle people are almost like a clockwork catching up on the active arm people just in about 3 months, exactly the same as it happened in the first 3 months in the original study.
Right. And also they're starting and stopping too. So they're
Correct.
not necessarily getting it every day like they did, or twice a day like they did in the first 3 months. So that's a very important observation. You could always count on Leon. When there's numbers in there, Leon's a good numbers guy, right?
So I think the
give him my check. I give him my checkbook to balance. I can't balance my checkbook.
I'll take that, Jim. But the take-home lesson I think here is that when patients come back in a month or two and they say, I'm doing okay, but it could be better, the take-home lesson is that stick to it, because it is going to certainly get better and much better as you stay on the drug. I think that's the key message, clinically relevant part here.
And based on you looking at it as a monotherapy, right?
Correct.
Based on that. Now, the other point on this slide, hyperkalemia was evaluated because all the patients in the study have, in every study, right? They have blood tests, they have EKGs, they got CBCs, chemical profiles, etc. And so hyperkalemia was if it was above the upper limit of normal. Let's say it's 3 to 5. Right? A patient at 5.1 or 5.2, it was counted as hyperkalemia. And then you would look at it and it was gone the next time, or whatever, but there were 5% of the patients treated with Winlevi and about 4% in the vehicle that didn't get it that had some level of hyperkalemia. The good news is none of them had alert levels that raised a red flag where you'd start to say, wait a minute, what's going on? The EKGs that were done as in everybody as part of the trial in the beginning, there were no alerts there, and there were no symptoms. None of those patients had to be treated for hyperkalemia. So based on that and looking at the serum levels and all the analyses, no recommendation to monitor potassium levels. But the important thing is, because people ask, because they think about spironolactone, is that was put to rest also by this data. Right? So now we're moving on to, this is the trunk, what I was saying earlier. The trunk has the same thing, right? So going back, trying to go back. The trunk shows the same pattern of going up. And actually, they did a little better on the trunk. It was interesting. Now, they weren't applying it from the shoulders to the waist. If they had it on the upper trunk, they were putting on, not dotting it on the lesions, but in the region where they had it, the chest, the region where they had it on the chest. Right. I already mentioned the HPA axis, which is on the right. Okay. And about a little bit over 50% of the patients who received the Winlevi for 9 months on the trunk got to clear or almost clear with the Winlevi alone, on and off. Remember, that's on and off. Right. So here we are in summary. Okay. Significantly improved the IGA success, clear or almost clear by 12 weeks as a monotherapy. Significant reduction in lesion numbers versus the vehicle. Continuous improvement in IGA success that continued to climb up higher and higher with long-term use over 12 months, stopping if they got to clear or almost clear, and then restarting when they worsened. That's based on the investigator assessment. And it's a very sensible way, because you're delivering a drug to block the androgen receptors topically at the site of action within the skin that can be used in male and female patients. Recommended is about 1 gram twice a day, as long as they have acne of any severity and they're 12 years of age. Okay. So I believe, it's no different than what I said before, but remember, pediatric patients, the general consensus is that pediatric patients have different body surface areas. So we can't say absolutely it can be used, because we don't have enough pediatric patients that were studied, didn't get that approval. So that's why you have that statement. It's not FDA approved under the age of 12. Adolescence is 12 to 17. The rest we already covered. Right? And I believe that's it. So let's see if there are any particular questions, right?
Well, we are almost over time, but I think there is one question I feel it's really important that when it comes to the pathogenesis of acne, how significant is the idea that controlling the sebum is key to controlling acne? Because we never had anything like this topically.
Well, I mean, it's hard to draw an analogy to isotretinoin because of all the things that isotretinoin does. But a big effect that isotretinoin has is reducing sebum, right? I mean, that's a big part of it. Reduces sebum, C. acnes, drops down significantly, but it has a lot of other, it's not a fair comparison. But we do know, if we go back, and there's a lot of articles, Leon, we reviewed them and we've published on them, and there's been some more recent publications that the production of sebum by androgen stimulation is what starts the whole process. We just started further on down because we didn't have any therapy to talk about and there wasn't as much work done. But that doesn't mean it didn't exist. And so I'm kind of embarrassed that I didn't think about that all the years I've been talking about acne and then say, hey, don't forget, we don't have anything up here, but we got to get something up here. We focused on what we knew, benzoyl peroxide, retinoids, and there was enough to teach about that, right? But it really is where the whole process starts, right?
Exactly. Well, we are up to the hour. I thank you so much. That was really a wonderful, wonderful, eye-opening program that not only we learned a lot about Winlevi, but also the pathogenesis of acne with all the new nuances. So I thank you so much. And I thank the audience. Also, I want to remind Roxanne, the next slide with the next program, please. I do want to remind all the audience that we have another program coming up. I thank you to Sun Pharma before already, and then we have our new webinar on February 13 by Dr. Michael Cameron. He is going to discuss latest insights on an oral treatment for adult patients with moderate to severe plaque type psoriasis. Again, I thank you for your attendance. And thank you for the great lecture, Jim. Thanks, everyone.
Thank you, and thank you, everyone, for hanging in there. I know we went on, but there's a lot of information that people tell me is new to a lot of them, so we wanted to give it its time. Yeah.
Absolutely.
Thanks, Roxanne.
Thank you, everybody. Good night.
Good night.